I'm Michael Lanuti. I'm one of the thoracic surgeons at Massachusetts General Hospital in Boston, Massachusetts. Um, I'm in a rather large division of thoracic surgeons, and I'm the director of thoracic oncology for our division. I have clinical interest in lung cancer, esophageal cancer, mesothelioma, and I also have a translational lab that looks at novel treatments of lung cancer. Can local therapies be considered in oligometastatic non-small cell lung cancer? And the answer is yes. The local therapies can be defined as surgery, in this case in the question, versus radiation as another local alternative. And I think we need to define the consolidative treatment. That is the treatment being used to treat the primary tumor or the extrathoracic site of metastasis? And I think there's a role for surgery radiation in both of those circumstances. Patients that are eligible for surgical approaches should ideally have a single site of extrathoracic disease, although the literature now defines oligometastatic disease as 3 to 5 metastases in a single organ, which is rather aggressive. And the primary tumor that is ideally not associated with mediastinal or N2 disease. So that would be the ideal surgical patient, that is N0, single site of metastases in the brain and the adrenal gland, and good performance status. That's a great candidate for a curative approach to oligometastatic disease. What about N1 disease, hilar disease? In my mind, it's not a complete contraindication. Those patients don't do as well as the N0 patients, but if they're young enough with a single site of metastases, we still would consider using surgery as a local therapy for the primary. And then the question is, how do you sequence these treatments if you're going to use surgery as part of a curative strategy? I think no one really knows the answer. I think it has to be tailored to the patient, and I'll give you a few quick examples. So if someone has a 1 or 2 brain metastases and they show up with a left upper lobe lung cancer, we would typically have them have the brain metastases treated primarily with either surgery, radiation, or combination. Those patients would then be invasively staged with regards to the mediastinum and make sure that they have no N2 disease. And if that's the case, we would often take them right to surgery, remove the primary, and then let them recover and give them adjuvant chemotherapy. There are some cases where you might want to give the patient a biologic litmus test where you treat the brain met or the adrenal met first, give them some chemotherapy, make sure they don't have extended disease, or we say met out, and then in the absence of mediastinal nodal disease, remove the primary. Surgical approaches to the sites of oligometastatic disease should be considered in the context of a multidisciplinary team, where surgery and radiation are your local modalities that can be used, and they both have excellent results. A good example would be an adrenal metastasis. In my hands, we can often remove the primary and the adrenal met at the same time. And so that's actually advantageous. And then some people will say, what about a liver met or a bone met? We have done a few bone metastases in very select cases, although frankly, those were metachronous lesions and not sort of synchronous mets. And then the liver met, again, select patients where you can consider some kind of liver resection or SBRT. Again, the patients have to be carefully vetted in a multidisciplinary fashion. So there's a lot of nuances to this. Yeah, so the adjuvant therapy for, let's say, an adenocarcinoma would be either a platinum with Alimta, 4 cycles, which is similar to the adjuvant for a resected high-risk adenocarcinoma, and for, let's say, a squame, it would be a platinum plus etoposide, 4 cycles. Whether there's a role for combining, a PD-L1 expressing tumor with immunotherapy, I think is under investigation. They are stage 4, so they're eligible. And so I think that's a work in progress.